Hi, everyone. Welcome. My name is Katie Parker. I'm a nurse practitioner with the palliative care team here at West Cancer Center. And today, along with Dr. Clay Jackson, we're going to give you a little bit of overview of what palliative care is and how it can be integrated. But we really want to get some of your feedback and questions. So please feel free as we're going through to stick those questions in the chat, and we will hopefully get to a lot of them as we go. So I'm going to toss it over to Dr. Jackson to get started.
Thanks a lot, Katie. As we said, we are a palliative care team from Memphis, Tennessee, and we're excited to share with you today this presentation. So we'll start with basically the NCCN guidelines, the National Cancer Certified Network Institute guidelines. It says palliative care is not simply hospice care, and we'll talk about the difference there. It refers to patient and family-centered care that optimizes quality and end-of-life care. I would say even now, palliative care is broader than end-of-life and may actually promote longer life by helping patients stay in treatment. Again, we could talk about that later. It's an essential component of cancer care. It's ASCO recommends that you provide this to patients at the beginning of care, that it's available. It needs to be continuously available throughout the treatment surveillance and during bereavement, if that's applicable as well. So you follow up with families. It's multidisciplinary. It involves docs, nurses, PAs, APPs in terms of NPs, mental health professionals, social workers, and also spiritual counselors. If you're an NCCN designated institute, you need to have a member of the PC team as part of the cancer committee. So what are the types of services that are available? Care planning, so decisional support, also communication, continuity of care across clinical settings, so inpatient, outpatient, home setting, et cetera, attention to spiritual and psychosocial support, as well as bereavement support, and then hospice is a smaller piece of that. If they're not provided on site at the facility, you just need to make sure that you also provide that in another setting or through referral. And then that's, again, the compliance piece in terms of NCCN guidelines. I just think it's a good place for us to start in terms of understanding that palliative care is needed. What does palliative care do? And what's this guy doing holding this tree? Palliative comes from the Latin pallis, which means cloak. It's an idea that we put something around the patient to sort of keep them warm and dry. This guy who's hanging onto the tree is in the middle of the hurricane. He's not going to be able to change the weather, but he can change his experience by having this cloak on. So that's the idea of palliative care. Palliative care may not be able to change the core illness. We leave that to our treatment colleagues with respect to anatomy and plastic therapy. However, we can change the patient's experience by treating pain, nausea, vomiting, constipation, anxiety, insomnia, etc. So it's management of symptoms, chiefly in patients with advanced disease in whom medical recovery is not expected. I would add to that management of symptoms that it's also communicative support with respect to treatment decisions. So somebody with advanced illness, there's symptom management and also decisional support. If patients have easy symptoms, they have easy decisions, palliative care is not needed, but tough symptoms, tough decisions, we might be needed. Patients get symptom relief, families get support and guidance in help with decision making. Clinicians in your institution get subspecialty expertise to lean on, and then systems hopefully get improved efficiency and quality of care. And that's the promise of palliative care and what it's supposed to do. How do we deliver it in oncology? There are different models. Inpatient services, which are consultation based. There are inpatient palliative care units, which are dedicated. There can be an embedded RN specialist, a clinical nurse specialist who can assist in palliative care formats, whether it be outpatient or inpatient. Outpatient clinic, that's what Katie and I do. We're an embedded clinic in a cancer center here in Memphis, Tennessee. Or there can be home-based palliative care programs. And I have nurse practices that I've trained that are involved in multiple healthcare systems around the city that do home-based palliative care as well. In our institution, this is sort of what it looks like. We try to frame palliative care as part of an overall patient experience. We have the patient and family at the center of it all. We have an urgent care clinic, which tries to help people with urgent needs, help them keep them out of the ER. Care management, we have care navigators that help. Care support services, which include psychology, nutrition, chaplaincy, social work. We have an inpatient team of palliative care clinicians, an outpatient team, that's us, and we also have an in-home team that I referred to. And some of those are dotted line relationships. They're not all managed by our cancer center, but it's people that are sort of involved in our training program and our sort of circle of influence and circle of clinical care. And finally, in our cancer center, we are blessed to have an integrative oncology division that involves physical therapy, art therapy, and other forms such as acupuncture of sort of non-pharmacologic or non-surgical interventions for patients. So that's kind of our picture of how we do it. What are the hallmarks of an integrated palliative care program? Well, the clinicians need to trust the palliative care team. I would say this is clinicians, including physicians, APPs, such as PAs and MPs as well. The palliative care teams needs to be scrupulous about care coordination, and that certainly involves prescriptive power. Advanced care planning needs to be routine for all cancer patients. The palliative team should be highly visible in the cancer center. Clinicians share responsibility for initiating palliative care consults. You're not just going down the hall saying, please use us, use us. Everybody recognizes the need and they share responsibility. And then the oncology clinicians themselves are trained to provide a baseline or primary level of palliative support in order that it's not you're at the end of a narrow funnel and getting all the patient need. Those patient needs to be met at the point of care, and then subspecialty colleagues are consulted when the primary oncologic colleagues feel that they can't handle the decisional support or the symptom management on their own. So basically, Katie, that's what I have in terms of the overview, but I think we have some questions from some of our colleagues here that have already come in and some questions we anticipated. So do you want to lead with some of those questions and triage them for us?
Yeah, so I think one of the top questions that we get is, we kind of hit on this a little bit, is, but hospice and palliative care are the same, right? They refer the same patient. So the same patient that would go on hospice would go on palliative care. Dr. Jackson, you actually have a special knowledge in this because you spent time as both a hospice medical director and as our palliative care physician. So can you tell us a little bit more about that and give us a picture of what patients might actually be good to come to palliative care versus hospice?
Yeah, absolutely. So first, a visual. Let's think of palliative care as a large platter or a charger. And let's think of hospice as maybe a saucer or a plate on that larger platter, because palliative care is more inclusive and involves more care teams than does hospice. Here's the core philosophic difference. In palliative care, we may still attempt to cure the core illness. We may still attempt to cure the core illness. So antineoplastic treatment is included in palliative care, whereas it is not in hospice. In hospice, the patient's no longer taking chemotherapy, for instance. And so that's one difference in terms of philosophy of care. I would mention that palliative and hospice are both philosophies of care, not locales of care. In our palliative care clinic, we follow many patients into survivorship, and we have some patients that are with us months, years, rather than weeks, months. And so the time course of care is also a little different for palliative care and hospice. As you know, Medicare certified hospices have to certify at the initiation of hospice services that the patient is expected to live for 6 months or less, and that caveat is not involved in palliative care.
Yeah, and Dr. Jackson, talk a little bit about some of the studies that they've done of, you alluded to it earlier, that sometimes people with palliative care actually may survive longer than expected than those without palliative care.
Yeah, super point that you make, Katie. Some people may be familiar with the TIML study, which was, I believe, a JAMA study from around 2010 or 11. It was a lung cancer study with 3B and stage 4 lung cancer patients. And it showed that those patients that were referred early to palliative care had about a 30–40% survival benefit as opposed to those who did not. Surprisingly, those referred to palliative care actually received less antineoplastic therapy. So we can't chalk it up to sort of more carboplatin that the patients received. We're not exactly sure why that's the case, why those who had palliative care live longer. Here's what I'd like to think. I'd like to think if patients feel better, they can fight better. That if we can keep patients sort of in the game with their pain and symptom control, if we can keep them understanding their illness process and their journey through proper communication and decisional support, that maybe they have a more positive attitude about things and they can they can do well. How do you talk with patients, Katie, about how palliative care might help them in their journey rather than just prepare them, say, for the end of life?
Yeah, so I think something I hear both from patients and from colleagues is, well, I'm not sure I want to go to palliative care. I'm not ready to give up hope. And so there seems to be an association that palliative care is somehow giving up. What I like to tell my patients is it's not giving up. It's instead maybe adding in or redirecting our focus on what we're fighting for. So maybe we're really fighting to make sure that their pain is under control or that their nausea is under control. And so we're kind of redirecting that focus, but we're certainly not giving up fighting. And then sometimes, especially from colleagues, sometimes I'll hear, well, I don't want them to think that I'm giving up hope by sending them to you, that I don't think that their cancer is going to get better, or, you know, that this treatment isn't working. And so there's actually been some studies, and they're mostly pediatric studies, talking with parents about their level of hope pending the conversations with their treatment team. And it actually was interesting that the more honest the treatment team was with the likely outcome and things, that the more hope the parents had versus treatment teams that maybe kept it vague or dangled that maybe there would be some other treatment, but that other treatment never came. So having honest conversations about the actual trajectory of the illness and likely outcomes increased hope instead of decreased hope. And so one could think, oh, go ahead.
No, I interrupted. Go ahead.
I was just going to say, one could think of that like palliative in a way that includes palliative care, in that saying we're getting a team to help you along your journey is not giving up hope, but adding an extra layer of support.
Yeah, I think communication is very important. That phrase, extra layer support, seems to be very helpful for families. There are two strategies with this that don't involve necessarily communication. One is institutional, where you just put things, put palliative care front and center. It should be on the front brochure. It shouldn't be, you know, at some point in the illness journey. It should be from the beginning, so that patients understand that just like radiation oncology is involved, palliative care is involved. So it's just part of the overall care of the team. I think that's the best approach. Now, we do have a nomenclature strategy that some centers use, calling palliative care the comfort team or support team or something along those lines. And I think that's a strategy, and many well-respected centers actually use that strategy. I tend to think that it takes about 6 minutes for the waiting room to figure out which team is what team. I think patients are smarter and families are smarter than we give them credit for. And then, you know, we have these euphemisms, and I envision 20 years from now that we'll have the team of rainbows and light, you know, that we keep naming it in more benign ways. But, you know, palliative is what it is. There was a question that I think came in, Katie, about minority populations, and I think it is related to this idea of hope. Why do minority populations actually access palliative care less so than majority populations? And I think that's true with respect to hospice nationally. I'm uncertain as to whether that's true with respect to palliative care. Insofar as it would be, I think it involves trust. There are some people that, you know, view doing things as quality care. And if populations have been historically denied access to care, such as African Americans or Hispanics, sometimes those persons can be distrusting of folks who say you might not need this next round of chemotherapy. Well, my mom needs everything that person mom's mom will need. So I think it's important to frame our discussions as a quality discussion rather than a rationing of care, or we don't think this is appropriate for you. I think it's important to frame it as, you know, what are your goals, and to ask some questions and to have understanding. Patients and families, this goes back to the hope thing that you talked about, Katie. People who are seriously ill tend to have a more finely tuned meter for falsehood. There are more colorful ways to say that, but they can pick up when you're trying to feed them a line of something that's not appropriate. And I think having clinical reality and being very present for the patient and family and being very honest with them is the best policy.
We got a question that came in that said, what are the specific reasons clinicians would refer to palliative care other than pain management, which is actually kind of dovetails into our next question that we get a lot is, are all palliative care programs the same? Do they all work the same? And what exactly do you do? So while all programs, as Dr. Jackson kind of ran through the list of components, they all should have those components, but different programs may look different depending on what institution they're in and what population they're serving. For our team, we do a lot of symptom management. And, I would say that's probably the biggest chunk of what we do, but that is what is needed by our patients. There are other programs that do a majority of advanced care planning. And so I think it really just depends. But the key component of all is that these are multidisciplinary teams or interdisciplinary teams, and they're working within the institution that they're in to both serve the patients to the best of their abilities, but also to integrate well into the institution. You know, when we're thinking about symptoms that we mostly see oncology patients with that they have, you know, about 60 to 70% of patients do have pain. And so that often is the number one referrer of why we get patients, but they also, you know, have other symptoms that may or may not be well managed, especially once you start kind of working through one. Sometimes others present. We do a lot of mental health management because that can certainly exacerbate a fair number of other symptoms. And so there are a variety of symptoms. I think it's hard because pain is so prevalent in cancer patients that often gets, that's what we get labeled as, but we're really, we try and be experts on a wide variety of things that would trouble our patients.
I think you're exactly right, Katie. I mean, there's a known comorbidity between, or actually among, three common entities, and that's pain, mood, and sleep. So you can think of that as the unvirtuous triangle for patients: pain, mood, and sleep. And if you have one of those, there's a 60% chance that you're going to have the other, and that's bidirectional comorbidity. And actually, they're co-contributory as well. Your pain problems exacerbate your sleep problems, which exacerbate your mood problems, which exacerbate your pain, and all the way around that triangle again. So we see a lot of that. We do some nausea management. We do some anorexia management. We do some bowel management in terms of constipation. So basically things that our oncology colleagues feel like that they need subspecialty expertise at. That's sort of what we do. I would say in terms of decisional support versus symptom support, we're probably 80-20, 85-15 along the symptomatic side of things. We see a fairly high volume of patients per day compared to most palliative teams. And so we're doing a lot of symptom management in our clinic, and we may be sort of on the outlying edge of that in terms of the Gaussian distribution of most teams. In my slides, I apologize, I didn't, there was a question about what is ACP, because I did not spell that out, and it's advanced care planning, routine for all cancer patients. So this would be say a post form or an advanced directive of some type, should be routine for all cancer patients, not just when they unsuccessfully respond to a trial.
One thing that I know comes up in our clinic, Dr. Jackson, and I have a feeling that other people have had this come up as well, is what happens when you have a patient that you've set forth a clinical plan for, specifically related to opioids or other controlled substances, and they have kind of decided that they're not going to stick to the plan, and they've gone off the plan. How do you handle that? And how do you continue to have a good therapeutic relationship with the patient?
I think it's a great question. It's one that we've actually not only explored qualitatively, we've actually done a QI project here about, if you look at the literature of cancer patients and patients in survivorship that are seen by palliative care, abnormal urine drug screens, however you define it, runs between 20 to 40%. So the idea that people pull up on your parking lot and suddenly become an ideal patient and a halo appears above their head and they always follow your directions is naive at best and harmful at worst. We need to understand that these patients are under tremendous pressure. They have tremendous challenges, both physical and mental, as well as psychosocial. And so it's important for us to be compassionate, but to be realistic. I think if a patient is not adherent to plan, I think we need to understand why. Not everything that involves early refills involves addiction or diversion. Sometimes it's pseudo addiction. Sometimes patients just don't understand the plan. Katie, one thing that I know you've done is even with the changing of fentanyl patches, you've given calendars to patients and said, change it on this day at this time. Because what we found in our practice was we'd send somebody 10 patches and say, come back in 30 days. And we thought nothing could be simpler. And wow, did they have adventures with those patches in those 30 days. So, really breaking it down, not talking down to people, but breaking down things for people is important. I think that's helpful. We do find that there are some patients that we have serious concerns about diversion or abuse. If they have active disease, we continue to treat them with analgesics, including opioids. We've made that decision as a team, but sometimes we will reserve abuse deterrent formulations for those patients. We have frank discussions with the patients about why we're doing that. And what we've found is that about 90% of patients respond very positively to that. They stay in our clinic for care and they rate us very highly, not only in terms of our concern for their safety, but our concern for their well-being and their comfort. And we found that that they actually rate us at about the same as patients who were not put on a sort of abuse deterrent protocol. So I don't think the mechanism of analgesia is the key. I think the motivation for communication is the key. And I think most patients will respond very positively to that.
We have a question about logistics and follow-up in our clinic. And so the question is, do most patients follow up monthly? And then how do you and I kind of trade patients? So Dr. Jackson sees all new consults and I see follow-ups. We don't really have a determined plan as to, you see Dr. Jackson 1 month and then me 1 month. Sometimes that's just frankly based on scheduling and who has availability. Sometimes, I find that if I'm working with a patient on trying to improve adherence or working on a specific symptom, sometimes it's more helpful for them to come back and see me a couple of times to continue that work and then kind of switch back and forth. And I would say about 50% of our patients follow up monthly. And then at various other time periods, I would say the majority are within 3 months. We have very few kind of 6 months or longer follow-ups. And most of that's related to having to see them every 90 days for opioid.
Yeah, so if someone's on a class 2 drug, whether that's a psychostimulant such as methylphenidate, or if they're on a class 2 drug for pain, such as hydrocodone, oxycodone, and others, then they must be seen every 90 days. That's a federal rule. And just because a patient is in palliative care, that federal rule is not exempted. Most state rules for chronic pain, such as urine drug screens, et cetera, they're exempted from regulatory status, but they're not exempted from the 90-day rule. So I see all initial consults. I generally see them in the follow-up unless there's some kind of emergency. And then at visit 3, they might continue to see me or see Katie, depending on what's happening. And we usually try to send our patients kind of back and forth every now and then, so we get that second set of eyes. And so, Katie, I think that we're up against time, but it's been a stimulating and wonderful conversation. I think our colleagues have sent forward some great questions today, and I've enjoyed engaging. Do you have any closing comments for our colleagues in the audience today?
Just to, hopefully you have a palliative care team where you work, and I would just encourage you to get to know them and utilize them, as I think it is such a benefit for your patients, even if it's just an extra set of support as they walk through this journey, and that's really what we're here to do. So I hope that you utilize the folks where you are.
Well, thanks very much to everyone for attending the conference and for attending this session. And we wish you Godspeed in taking care of your patients.